Good morning and welcome in, everyone. Thank you so much for being here. My name is Zane May. I am with Wichita State University, and I'm helping KDADs to facilitate this meeting and make sure that we have things running on the technical side. So you probably got a note that this meeting is being recorded. That's so that we can share this later as needed. You will need to go ahead and give permission to be in the meeting. We have an hour here today, and during today's meeting, KDADS is going to be presenting information. There are 3 other meetings scheduled this week in which there will be some more presentation, discussion, and chances for you to ask questions. Today's meeting is to get set and to kick off so that we have uh, good information as a foundation to carry out the rest of the meetings for the week. So I'm going to go ahead and hand it over to the KDADS team so that they can kick us off and use this hour for their presentation. And the KDADS team that we have on here are Matt, Melissa, Heather, and April, and I'll let them introduce themselves more as they see fit. Matt, I'll go ahead and hand it over to you first.
Yeah, welcome in, good souls. My name's Matt Spezia. I'm one of your CCBHC specialists. I'm here to assist with TA stuff. Today we'll be talking about our CQI expectations, and Miss Melissa will be leading a large section of it today. She's part of the quality team, but I'll let her go ahead and introduce herself.
Good morning. Thank you for joining us. I know that a lot of things hit on Monday mornings, and you're off to your busy work week. So we really appreciate the time, and we'll use it. I'm Melissa Boyd. I see lots of familiar faces on here, and really look forward to the content. We're also going to share a few case studies. So I'm glad to see our friends Lori Weibel and the Crawford crew here. Glad to see Crosswinds. So yeah, there's so many people. So I wish I could go through and say good morning to all 30 of you, but like I see you. I'm so happy you're here. Thank you for joining us.
Heather and April, do you guys want to introduce yourselves since you're also on?
Mm, Sure. I'm Heather Rush. I've been with the team for 2 years, so I'm not presenting today, but I'm here for questions or anything that's needed. Thanks.
You're on mute, April.
Hello, I'm April White. I'm the CCBHC Program Manager at KDADS. Also not presenting, but happy to be here.
Well, wonderful. Well, let's go ahead and get started. I'll pull up our PowerPoint here. If my mouse wants to click through, there we go. So we already introduced ourselves. These are our emails. As you all know, the KDADS emails are really easy. It's just first name dot last name at KDADS. But I'll let Melissa go ahead and get into it.
All right. So everybody on this call has been through a CCBHC certification process. And so there's a lot of uploads that you provide to us data-wise before we get started. And the first thing that we start with is your community needs assessment when we're sitting down to look at quality. If you've been to NatCon, and I'm sure most of you have, you'll hear them say that the community needs assessment is the third prong to the CCBHC certification process. So there's what the federal government requires, there's what KDADS requires, and then there's what your community tells you that they need. And what we're really looking for when we're looking at the community needs assessment is finding out more about the cultural and linguistic needs of your community. And so we're looking at, that you're and not just dialing in that census level data of languages spoken or percentages of households who speak English at home, things like that. We're also looking at what you're doing as far as outreach and engagement to get those voices included in your community needs assessment. So how are you engaging, in the community to make sure not just that you're again at that census level, but that you're at that service level of what would it take to best serve the individuals in our community that may, for a variety of reasons, have historically not accessed mental health services or substance use treatment services in the way that you want your community to, and to be that resource and that partner you are as a CCBHC. And so looking at your CNA findings is enormously helpful as we look at that third part of CCBHC certification, which is how are how are the community partners and the center working together, so that as the next 3 years after your community needs assessment progress, we're seeing from a quality lens all of the things that you're doing to increase your outreach and engagement, and that your enrollment and your demographics are reflective of your service community. And so, and also I'll just say that I think there's a lot of prolific grant writers on the call this morning. It's not just an effort to, work through quality assurance with KDADS for CCBHC certification or recertification. The very same cultural and linguistic data points that you're collecting here can be used in a variety of ways to attract foundation funding, funding from different organizations and causes that are aligned with the community needs that you're seeking to serve. And so I think there's just a treasure trove of data in your community needs assessment, and it's where we start to really notice how centers are focusing in on those CLAS standards and embedding them in their service array and how they approach service delivery in the community. Matt, do you have anything to add there?
It would help if I wasn't muted. Yeah, so when we know that Kansas is a very unique state with the amount of languages that are spoken. We know that there's 91 different recognized languages. And while we're not expecting our centers to have proficiency for 91 of them, digging deeper into it, and we do have a couple of case studies, we're creating a community of care here. And that means being able to assess everyone and being able to let them feel at home when they walk through our doors. No wrong doors, and we want to make sure they feel like they're accessing that community of service.
So I said I was going to talk about Crawford County, and this goes back to getting beyond just what the demographics, the census level data are telling you. And so, Crawford County Mental Health Center could have looked at their Marshallese community and said, it's only 4.5% of our community. And they could have said, we work with Propio, as most centers do, or another translation service. That's such a small part of the community. Noted, it's in the community needs assessment. We'll leave it there. That's not what happened, though. And I'm very, very proud. This example always stands out to me about how, in the case of Crawford County, there was a need, and in working with the health department, there was a need to build trust and rapport with the Marshallese community. I think when I was out there talking with the Crawford County team, it was very apparent that not only was there mental health services needs within the Marshallese community, but there was also some risk around tuberculosis. And so taking that whole person care approach and looking to see that, hey, there's this community, but until we build trust and rapport with the community's leadership, they may not be able to access services in the way that they need to, not just mental health services, but really building health literacy and outreach to all parts of the community, even ones that, are single digit as a percentage, but have a huge impact on the overall community health and well-being. And so thinking about what Crawford County did, it should be an inspiration to all of us as we think about faith leaders, cultural organizations, advocacy groups, and clients themselves that can really unlock, those partnerships that are not as easy or apparent to some of us, but that carry really kind of the spirit of CCBHC, which is not sitting in the four walls of a clinic waiting to see who shows up. It's about proactively going out there, finding the people who need the services, and then making the services accessible to them, including on a cultural and language level. Matt, do we have anything to add there?
You are doing an excellent job here. And it is, when you talk about just 4.5%, that number doesn't sound large, but it dramatically impacts the community. And seeing Crawford County's study is, like you said, Ms. Melissa, just an excellent inspiration of truly making that community of health.
So compliance, I know that's everybody's favorite word especially for a Monday morning. I hope you got a lot of coffee to go with your compliance, but we can sit here and talk about just a little bit. I won't read PowerPoint bullets to you, but I do hope that you'll use these slides as a resource, and I'm sure that Zane and the team will make them available after we're done with our conversation. And at the end, we would love to hear your thoughts and questions too. But we want to make sure that the practices that we're seeing evidence of from a quality assurance standpoint is that that the services are effective, equitable, and respectful to the diverse cultural health beliefs and practices in the community. I know there's centers on here who work, extensively with tribal communities as well. That was a huge focus in the CCBHC certification criteria is making sure that with the CCBHC model of whole person care, it's all about care coordination and really looking to see how you can work on improving communications with across the community, but also and shoring up that health literacy. And kind of back to the Crawford County example, it's not just about health literacy when it comes to mental health services. There's a lot of need to recognize how cultures, may have unique barriers or stigmas to accessing mental health or substance use treatment services that need to be approached differently. It's about recruiting, promoting, and supporting a culturally and linguistically diverse employment group. And I've noticed in our travels across the state that we're seeing more and more bilingual staff. So kudos to the organizations that are out there, working to recruit a staff that really mirrors the diversity in the community that you serve. And then training and education. I love that with CCBHC, we've seen organizations, really focus on veteran services training and understanding veteran and VA culture. It's a huge point of emphasis. It's one of the 9 CCBHC services. So not just about linguistic and cultural diversity when it comes to different racial and ethnic groups, but also the lived experiences that people might have that are also part of their culture. And I think that we could all agree that communities like the veteran community have their own culture, military culture, that needs staff that has been trained to appreciate the steps that someone must go through to seek care and access care from the VA. Those different centers that have added the principal behavioral health providers for veterans that help educate the entire staff on what it means to serve a veteran well and how to engage with members of the families of people that are serving in the armed services. These are all examples of common practices that we see every day and that we're really proud of that are being undertaken at centers all over 105 counties. So kudos to you guys for really all the work that you've done to be compliant with CLAS and really in many cases going above and beyond just what these common practices are.
And here's another one of our favorite words early on a Monday morning. CCBHCs consistently are one of our best tools on de-siloing efforts. When you create those, again, communities of health, you're bringing together all peoples and de-siloing people from these services, making them feel accepted, not only culturally, not only racially, but with their lived experience. When you help break down those barriers, you allow access for everyone to get services. And you all have done a great job at looking at that and building that true community. But we know that CCBHCs are one of our best ways of de-siloing things. And that is a continued effort in Kansas. And we are proud to see those walls starting to break down, those stigmas starting to fade away.
So I think if we did hands, I don't know if you can raise your hands on the Zoom. I haven't played around with all of the things. So somebody can try a reaction just to see if it works. But by show of hands, of all the centers that are on the call today, I think Proprio is the big show in town when it comes to providing translation services. Is anybody using a company that's not Proprio? Can you raise your hand or signal?
Yeah, or you can put it in the chat if you have an answer there.
If you could put it, okay. So because whenever I think about language assistance, I think Proprio, but if there's other services out there, feel free to share because I think that people are always looking at, great ways to bridge those language gaps. I've also heard of a center that uses earphones, and I haven't tried this. I've been wanting to find these headphones, but that basically the front desk folks, they're the front door to the organization. I know that they have the ability to put these headphones in, and if somebody's speaking a language other than English, it helps with the translation back and forth. And so they also use Proprio at that center, I believe, but just multiple ways, and including, having bilingual staff. Is anybody really struggling to find language assistant resources to aid and facilitate that communication? Is there a need there for us to maybe do more of a deep dive on the resources that are out there and available? You can also put that in the chat, because I think this is a great time for quality assurance and for Matt's team, which includes April and Heather here, and CCBHC technical assistance. If there's something that is needed, or if the state, could provide more multimedia materials, maybe on 988 or other things, like, let's make this a dialogue and let us know what your needs are. But we've noticed that across the state, when we're going into your lobbies and we're seeing that there's so many centers that have most of, if not all of, their written materials translated into what we commonly see as Spanish. For many of our communities, we consistently hear about Propio being available to do the translation on the call. We know that more and more centers are hiring bilingual staff members. What about crisis, though? This is something that I've often wondered about, because when you know somebody's coming in and you know that there's a need, that you can plan for that. You can get Proprio ready to go. But I'm wondering if anybody has experiences out in the community, maybe with your mobile crisis services, where you've run into challenges with language assistance, or is it working just as flawlessly as it does in the office? Is something for us to think about, because what we can do in a controlled environment, I think sometimes might be more difficult than what we can do in a mobile crisis environment where the needs are unanticipated and they're unscheduled services. So if anybody has ideas or has challenges that they would like to share, around what happens outside of the office in the community and on those unplanned crisis visits, I've often wondered if there's challenges there related to language assistance that we should be tackling, or if that's well in hand. So feedback would be appreciated, but thank you for all you've done to translate your materials, to enlist the services of translation companies to help with that communication. It looks like Michelle says that, you've got some bilingual staff out there, and I'm looking forward to that conversation. We don't plan to do PowerPoint the entire hour. We want to get into those discussion matters. So be thinking about unique approaches that have served you well when it comes to communication and language assistance. So as you're thinking about your next needs assessment, what we've noticed, what Matt and I talked about when we were getting ready for today, is that a lot of organizations are kind of at that 3-year mark where, per SAMHSA guidelines, you need to do another needs assessment. So it'll be fascinating, I think, to look at what your first needs assessment indicated, as far as who are the people in your neighborhood, and then what your next needs assessment says. And I think it'll give you an opportunity to really see if there's new groups that have moved in the community, if there's growth, and there also outward migration, where we notice that there's rural communities in Kansas where the population is getting older, but there seems to be, a lot of outward migration of younger folks. And so I think always understanding the demographic changes in your community and having plans and strategies to be able to promote that engagement and that continuous quality improvement around that outreach, and having your community assets ready and available and aligned to what you're seeing in your needs assessment is just so critical. And so if you have questions for the KDADS team, in the past, we've received permission to share community needs assessment reports from centers that have really invested in getting to that engaged level with different members and different cultural groups in the community. If you'd like to see examples as you plan for your next community needs assessment, I think we'd be happy to go in there and help. Because again, census data is in every community needs assessment, but it's really the more actionable data is what you're going out and being able to collect through real in-person, community meetings, through focus groups, through surveys that meet people where they are. and really get that feedback that's beyond just statistics and trends. So Matt, anything to add there?
Yeah, and we'll be over the next couple of days really diving into what it means to be data driven as an organization. As you read through SAMHSA guidelines, that's another phrase that you'll hear a ton. Um, but like Miss Melissa was saying, not just the census data, but meeting people where they are, finding where they're meeting in the community and developing partnerships there, through churches, community center events, gatherings, sports centers, wherever people are gathering, that's where we want to see partnerships come from, because that's where the community is happening. And that's part of that cultural competency, is knowing how your community interacts with itself and putting yourself in the center of that. You should be always striving to be a hub for your community. Not only does open doors mean we want to see everybody that wants services, but open doors means creating that welcomingness, and having that community-based focus really does do that. And when you're looking through your community-based needs assessments and seeing where you can find, better options for meeting people here, better ways to get people through those doors to come see you, that is so much about that is coming up with culturally competent ways of conducting yourself.
Mhm. And I'm measuring it. So at the end, when we broaden this out to a conversation, I would love to see, not because KDAD says, oh, you need to put this in your CQI plan, because we'll be back for recertification next time around. I'd love to see proactive, continuous quality improvement metrics. Not that they're even when we're meeting all of the CLAS standards, to say, here's a goal that we have for ourselves, maybe frame it as a SMART goal, that because we know that we have a community that is underrepresented in our service community, we have a goal to expand this many services to this many folks in this period of time, and maybe what types of services they are. So if school-based mental health services, maybe you've got a new bilingual school-based therapist. Maybe a goal could be, really looking at engagement numbers and retention numbers to say, how are we doing at making our service array, our service community match the community at large. Okay. So crosswinds, who here, by a show of hands or another reaction, I don't know what's possible. I should play with the controls here. There was a great news article, and it's something that we also learned about when we were visiting Amanda and the Crosswinds team. So I was happy to see Amanda and Lauren, I think, join this morning, so I could brag about you a little bit, because more than just having bilingual staff, which is awesome, and having ProPio available, I loved this coverage that Crosswinds received about their El Centro clinic, which is from the ground up, and every square inch of it. It's not just here's a clinic that has a lot of Spanish speaking staff. This is a clinic that's culturally aligned to welcome people that are Latino and Latina and Latinx culture, and really to make it, it's not just about the languages. I love this quote. It's about having that bridge and really seeing the whole person, including all of their cultural and having an understanding of those cultural practices within their culture. So I really think that when we look out across the Kansas landscape and think about excellent examples of really walking the talk, and getting more than just speaking the language, kind of hurdles accomplished, really culture approaching it, that people that can come in and see that everything in this clinic is anchored around the cultural practices and cultural understanding of people that are Spanish speaking. And so kudos to the Crosswinds team for taking kind of that class to the next level. I just really love that example. So, and if there's, I don't mean to miss anybody, if other centers are working on, expanding clinics or shaping their clinical models in ways that uniquely are tailored towards, being a culturally welcoming place, please share those examples. We love to hear it.
So this is when we get to talk about data. Um, so we know that being data driven is such an important part about being CCBHCs. And not only does this data allow you to make more effective, better performance, better accountability, and at the end of it, seeing much better outcomes, but allows us to be more advocating. When you create these big communities and you have the efficiency in your outcome measures, and it's the continuous part of it, nobody's asking for perfect, just a little bit better every day. And understanding our cultural competencies, measuring it, and seeing where you need to tailor different approaches to really envelop your entire catchment area, you create the efficiency here. And the effectiveness comes from data knowing exactly how you're going to serve, who you're serving, and being prepared for whoever is going to walk through that door. And you are encouraging the entirety of it. And we love to see our centers, and we love giving these shout outs and seeing the effectiveness of it really coming into play. You know, this is a huge program, and it's a national effort through the demonstration. And we can already see that these indicators are becoming better, and we want to continue to be able to move forward. And that does pull into the new data quality measurements of it. And this image right here is from the brand new SAMHSA thing. And Jane King, our presenter over the next 2 days, is going to go a lot deeper onto our data. But establishing the critical review process of CQI outcomes is something that we really do need to see. And the better the data that you give us, the better the data that your own centers are utilizing, the more relevance we see, the better accessibility, timeliness of things. And because we know our communities change relatively quickly, you know, one new trend for youth can completely change how they're viewing viewpoints, a new stigma going through, you know, an older generation of, oh, we can't go talk to these people. We want to break down those walls and again, de-silo ourselves. And the accuracy and reliability of that data is something that we really do want to emphasize. The more you're uploading into AIMS, the more your own centers are utilizing it, the way that you talk about data can really drive the way that you're implementing your improvements. And then the integrity, obviously, part of it. So our scientific integrity, being able to really measure these data outcomes and see where improvements are happening. What can the state focus on more for policy-wise? How can your centers better address the communities that you serve? And we know the love and effort that you put into this. No one says mental health and behavioral health is an easy job, and it's far from it, nor will it ever be. But when you look more at data, you can be prepared to be proactive, not reactive. And that's something that the CCBHC model really allows us to do. How it trickles through for better systems, how it trickles through for better dimensions of service. And again, breaking down those barriers. For so long, mental health was viewed as, oh, mental health, be careful. And now it's something that really is on the forefront that we're seeing, especially in youth. They want these services. They want to have a place to go and feel like their community is standing behind them with it. And improved patterns through utilizing this and creating true quality data makes for better reductions in emergency department uses, rehospitalization, and repeated crisis episodes. When people have access to services early, often, and feel safe in utilizing them, we know that an ounce of prevention is worth a pound of care. So when you do have these continuous improvements, you see your community really start to get behind you as well. As much as you hold up the community, they feel like you have a home in this community as well. And we do want to start talking with you guys here. So does anybody have any points or anything that they would like to come off mute and share some success stories with what they've been able to do? I mean, we would love some. Um, I know it's a Monday. It might be a 2 cup of coffee type of day. It is rather gloomy and rainy out here. So, but on our other question, we were seeing some answers for other language services, Avant, Global, and Genie. So we love seeing the different utilizations of language services. Again, Kansas has 91 different recognized languages spoken across the state. So it is a large effort to get over that hill with it.
Hey, Matt, it looks like Michelle came off mute.
I was just about to say.
Good morning. So, yeah, we use Avant, and then that's something we use across our county, and they will actually it's an easy call-in service and can also translate some documents if needed, which has worked really well. And then I had also spoken a little bit to like going out on mobile calls. What we found within our crisis center is that most often if somebody comes into crisis, they're bringing somebody with them that will help translate. And that has actually resulted in some contracts for us as well. When we've had somebody come in needing sign language, they brought a sign language interpreter and we were able to use that interpreter and pay that interpreter too. So we try to be really creative with that, though it's not always easy. But that's what we've done with crisis. But as I've been listening to you guys today, everything that you have said is so beautifully said, especially Matt. I appreciate the way that you're wording a lot of things. And I would say that in listening to you guys, there's nothing more that I want when I'm doing a community needs assessment and working on CQI than to try to figure out how to improve and work towards providing the best quality care that we can. But also as I'm hearing you, I'm feeling like burdened because I'm like, there are so many pieces of CCBHC that we're trying to do well. That for me in particular, with the community needs assessment being something that's every 3 years, it's like, gosh, I got to put that on the back burner so I can focus on this fire and focus on this fire and focus on this fire. And I'm like, oh my gosh, I have a few months to really focus on this community needs assessment. And I want to really do it really, really well. But I also know that I have 8,000 other things that I have to do. So I'm definitely going to do the best that I can. But it's a struggle. And I'm thinking others may feel the same way as well.
And it definitely is a lot, and especially with this, being in our demonstration of it, it can feel overwhelming. But the cool part is we're building this together. It's a team effort. It would be so impossible to try to tackle this alone. So we love seeing so many of our centers and seeing that example from you. It is a lot, but it's something that we get to build together as part of a team here. Like we all work together on this. Like I know occasionally when you see our TA emails come through or quality assurance, you look at it, it's like, oh, here comes the state to tell us what to do again. No, we're building this together. This is a team effort, and there is so much of it. And we know Kansas is an incredibly diverse place. So when you're bringing an ASL interpreter on a mobile crisis call is amazing things. Thank you for sharing that.
Yeah. And I hear you about the community needs assessment with all of the other things that you have going on. It's like, wow, 3 years have come and gone. I would be interested, do you think the toughest part of the community needs assessment is the engagement piece? It's getting out and getting kind of real people feedback instead of census level data?
I think for us here in Sedgwick County, one of the things that I found, and I see Becky unmuted as well, but one of the things that I found is there are so many community needs assessments in our community that like the health department's doing one. I know Camber just did one. I know that there was a collaboration within universities here. So there's so many community needs assessments that I don't want to duplicate what others have done. And I like to use what others have done and share what we do as well for the greater good of the whole community. So I think that's an interesting thing that I've found with community needs assessments.
And Becky, you came off mute. Go ahead.
Yeah, I think our biggest hurdle was kind of what Michelle said, is creating it. We can get it out there and we can ask people and we can have meetings and town hall meetings and whatever to fill it out. But it was mainly creating it so it's not duplicative. So it's not overwhelming, because communities, I believe, are getting worn out of needs assessments and not seeing the results. Like we have 10 counties. And so for those that have more counties than that, I can't imagine. So we're trying to create an assessment that isn't duplicative of what everybody else is doing. So I think that was the biggest hurdle for us. We created a very, very, very short needs assessment. And hopefully when KDADS views it for our upcoming site review, they'll provide us some feedback. But I'm really excited to hear about that as a collaborative effort, because Melissa, I would have reached out when we were creating this and say, help me, guide me. What do I need to put in this? How do I put stuff in this? How do I get the data back? How do I interpret the data? Like, I am not a data person. So there are just so many things that would be helpful to receive guidance on this.
Let's
And
keep that
Christine just put in the
conversation
chat,
going.
yeah, 20 counties, and it is challenging because each one of them is going to have their own diverse needs and finding little pockets of things. Like I live in an itty bitty little town in Alma, and even they have various community meetings and different cultures, different age ranges, different growth experiences, and that's in a town of 600. When you start scaling that and finding those little pockets of things, that they add up very, very quickly. But when you're
Mhm.
talking about the design of your community needs assessment, I do like, keeping it small, integrating what you can from other places to see that whole picture. And that's why we encourage community partnerships with these organizations, because they're going to be able to touch nooks and crevices that you may not even have known existed. But by bringing those in, they're bringing in just different avenues that we were going to be able to touch, even if we spent a year scoping out a community. The natural community organizations in these places are going to be able to reach everyone. And it's a great idea, Michelle, to reach out to as many different places, because they're going to be assessing different parts of your community to bring that whole picture together. It's finding every puzzle piece to make the whole frame.
Yeah,
Okay, so I
those
have
are
a
great
question.
points. Go ahead.
No, go ahead, Melissa.
I was thinking about what you're talking about, the hospital, the IRS, I think, makes hospitals do them every 3 years in most places, the health department. One of the things that I've noticed is that when a hospital does a needs assessment, they will it's kind of like a big headline. They'll have a statement around maybe that the leading cause of emergency department utilization amongst youth 8 to 14, let's say, is a mental health crisis, something like that. But what we don't often see when we see, like, okay, our big emphasis is mental health from a hospital lens, or we have like ED admission rates that of this age cohort that are in the mental health space. What we don't necessarily see after that is what the why, like what is causing that. Is it because families don't know about the resources to access services for their children before it's an emergency department visit? So one of the things that you might think about is when you're looking at, yeah, okay, the health department's done one, and here's their tuberculosis figures, or the hospital's done one, and here's their youth emergency department utilization around mental health, or is to start thinking about, what could you ask the community if you were to go to them and say, okay, we see, did you know? Because they may not know, right? Did you know the leading cause of, youth admissions to the emergency department in our community are mental health related? And then underneath that, say, what do you think are the top 3 reasons that somebody might choose the emergency department for mental health crisis? And like, have them tell you. Maybe it's they don't know anyone else to call. Well, that's an opportunity to educate the community on what mobile crisis services that you have. I think a lot of folks still think of behavioral health as being somewhere where you go, and so I think that there's a lot of, nationally, you can look at the facts and see that there's a lot of ED boarding, um, where obviously people are going to the emergency department in search of that higher level of care and then waiting for a bed to come up. Maybe it's because they don't realize all of the things that can be offered and delivered in the community. And you guys do an amazing job, but I still see centers, working really hard to let people know they're there. I mean, there's centers that have beautifully wrapped vehicles all over town all the time that say, here's our number, call us, we're here, we're here, this is us working for you in the community. I know that you do so much to let the community know you're there, but I think that people, when they're thinking about how to access mental health services, unfortunately, I think we're still in a crisis driven framework where people are accessing services a lot of times in the wrong place with the wrong provider, and they've waited until the timing has made their situation quite acute. And so I think that, yeah, there's a lot of needs assessments out there, but maybe taking the elevator down to that more granular level of data when you see a trend that's related to mental health. Like, why are people going to the ED so much? Is it because they don't know, or is it because, I think sometimes if you're in a community that doesn't have insurance coverage, the idea of calling a doctor's office, at least in the physical health side, and then what coverage do you have? And I don't have coverage. Well, then they delay. I don't know if the same is true for mental health, where, because you guys serve people regardless of their ability to pay. I don't know if that's an impediment, but maybe because people think, oh, physical health is something I can't afford. maybe they think mental health is something they can't afford. And so maybe the affordability piece is where we need to be messaging. It seems to come up a lot in the needs assessments. People still have this perception that mental health services are unaffordable to them.
Yeah. And creating, there's a really interesting case talk about this. Even if you speak the same language, your lived experiences shape what your heart language is. Like a veteran's going to access and talk about services completely different from somebody who hasn't served, or somebody that grew up in a household of abuse is going to look at asking for help very differently from somebody who didn't. Even if they speak the same language, they're going to have that lens of how to access services, when to access services, or even just thinking about, man, am I in a bad place, very, very differently from somebody who doesn't. And that's, again, the cultural competency of lived experience as well.
I have a question.
Yeah,
Is
absolutely.
it more about us creating our own, or is it more about using community needs data to address gaps? So is it for those that already have communities that do a community needs assessment? Is it possible to say, hey, this is the community needs assessment that we're using for this county, and this is the gaps for that county? And I know if you have 20 counties, I don't know how you would do that, but it's just a question, because we do have some communities, like Raleigh County is our biggest one here, and they do an amazing needs assessment every 3 years that we could never duplicate because they pay for that. And we don't. And then I was wondering, is it ever to a point where KDADS would consider having a position to be able to help us assess all the needs assessments, if that makes sense? Just to be able to say, okay, so Crawford County, this is your community, this is your needs assessment, this is the gaps, this is the population, this is the language that's most spoken. So that way we don't have to, I know this is going to sound bad, but we don't have to put all that effort into getting the data. We can put the effort into filling the gaps for that data, because like Michelle said, we don't have time. There's so many other things to do. But anyway, okay, soapbox over. Thank you.
Yeah, no, it's a great question, and we highly encourage you to use other, needs assessments, pull from all of that data, and yeah, reach out to us. We can help you, how to build an Excel sheet that can answer questions like this, how to look at data like that. And you'll see a ton of this in the next couple of days. We're having Jane King, formerly on the National Council, and she's got an amazing presentation about using data and being data driven and proactive with it. And she'll do a great job of diving in with it. But yeah, when we talk about partnering with community organizations, that is part of it. Use their data, let them use your data as well. Don't silo yourself away from this. Allow yourself to be that community hub and see, okay, here, like you said, here's Crawford County's awesome needs assessment. How can we fit in and get in here? How can we be that pillar for our community? What is needed here? Use their data, let them use yours. It's a team effort. Don't try to just do this alone. And Heather put a great comment in that I want to go ahead and read for us. Building those bridges between different providers within your community so that people can get the services that best serve them. And that's exactly right, Heather. When you use that other data to find how the community is asking to be served, people will often tell you what they need. And if you can listen to them early, it doesn't become a crisis later. Hopefully that answered your question, Becky. Yeah, if you guys ever need help, that's what the TA team is here to do. We're here to help you. We work at the state, which means we work for you. Ask for help when you need it. We're more than happy to hop on a meeting and give it to you.
Yeah, and with the changes that we've had on our team before Matt joined, with changing up how CQIs are being done, that we're not having those quarterly meetings. It's not that we're not accessible to you guys. If you guys have issues, we're here to try and help you find those answers. Whatever you need us to do, we're happy to look over. If you find something that it's like, oh, we're stuck here, how are we supposed to use this data to improve whatever? Sometimes just working with other sets of eyes outside of your normal group gives a fresh perspective, and we are here to help.
And from having teaching experience in the classroom, when somebody raises their hand with a question, there's a bunch of other people with that exact question. So please don't hesitate to reach out, because if you're experiencing it, other centers likely are too, or at least a version of it. So it lets us know where systematic things need to be addressed when you have questions. Well, does anyone else have something they'd like to talk about today? This was more of our, and again, you're about to see two great presentations these next couple days from Jane King, and then our fourth day on Friday. That's where we're going to really dive into questions and answers. So feel free to put them in the chat. Feel free to email Zane so we can come as prepared as we possibly can for those questions. This is such a massive program that, you know, you might have a question and we'll be like, well, we'll get back to you. But if you think of them between now and Thursday, please send them to Zane so we can come prepared to be able to give it to us.
And
Can
Matt,
you
just
please
to make
distribute?
sure, you said Friday, but the fourth one's going to be on Thursday.
Oh, yes, Thursday. Sorry. My second cup of coffee has not kicked in yet. It is not 10 a.m. Leslie Ward, could you please distribute some sample CNA surveys you think are helpful? Yeah, we could absolutely show you some models on that. Thank you for asking. And yeah, absolutely.
I think it's been a great discussion this morning. You know, I know Jane King's name's been mentioned a few times. I think that the way that we have organized this week is kind of to tell you kind of what quality assurance looks for. Matt has really shared, you know, what's available, and Heather as well from technical assistance, because we would much rather you work with the TA team to get your data where you want it to be than to come in and do a quality assurance review and then you have to say, okay, these are areas that you must improve upon, you know, and give that. I mean, it all works, right? We're always going to have some TA and some QA because as Matt mentioned, build the model together and improve it together. So it's a very healthy part of the process. But we're very happy to be bringing Jane in, and I don't know if Zane wants to give a little bit of a preview about what tomorrow will bring, but we hope that you and your staff will be able to join those sessions. I know it's a big commitment with all the other things on your plate, but I think it'll be one that's well worthwhile.
Yeah, so tomorrow's presentation is CQI integrations, and Matt, Heather, and April are probably all better able to speak to that than I am, and they've been working closely with Jane.
Yeah, I'll go ahead and talk about that. So for CQI integrations, like Leslie, you asked for to see models of it. There are a couple of case study examples, especially diving very deeply into addressing specific areas of your community. Jane's going to talk about a great veteran example model, and she's going to be pulling from other states too, because again, we know that Kansas was not the first to join this. Other states are ahead of us. So having somebody who was previously on the National Council, she's going to bring a lot of different perspectives and modelings and showing not only why it's important to be data driven, but the outcome measures that come out of that. Over the next couple of days, you're going to be seeing models, case examples, best practices, various study models, and her just depth of knowledge is going to be accessible to you. So, you know, she's going to present. There's going to be plenty of time for questions and answers. From what we timed out, it's going to be two about 40-minute presentations and then about 20 minutes to question and answer, similar today. But you're going to have direct access to one of the most knowledgeable people on these models and seeing examples from other states and what worked well to be able to plug in.
Thank you, Matt.
Absolutely. Well, y'all, if anybody else has any questions, please drop them in the chat or feel free to come off mute and speak. We don't bite, but we'll give you guys just a couple of minutes here to see if there's any more questions. And if not, we can hand you back a little bit of time in your day. Well, I'm seeing a couple of people pop off here and no red microphones disappearing. So yeah, looks like we're going to be able to give you just a little bit of time back in your day, and hopefully, thank you, Becky. And yeah, thank you all for your inputs and listening to us, and doing everything that you do to make Kansas better, healthier, and safer for all of us to be in. And we do really dramatically appreciate y'all's effort. You guys are on the front lines of making our communities just better. So we will see everyone tomorrow, and hopefully you guys get as much and more from Jan as you got from us today.
Thanks, everyone. Have a good day.
Thank you.